the next speaker is Lorna Dixon. She's a clinical specialist speech and language therapist and specialises in the diagnosis, assessment and management of complex communication and swallowing disorders. She was involved in the consensus recommendations for speech and language therapists in this clinical area. She was working at the National Hospital, but is now founder and lead of the private practice Illuminate Speech Therapy. So thank you very much.
Hello. So why do we need speech and language therapy in F&D services? So we already have a pretty good idea of the numbers of people that come through neurology services with F&D, but how many of those have communication or swallowing symptoms? Well, Butler et al. Did a great survey of over 1,000 respondents and found that about 65% of those currently had symptoms, and previously around 20% had experienced symptoms. In terms of swallowing or globus, a lump in the throat, around just over 40% currently had symptoms and around a quarter had previously had symptoms. And this pretty much aligns with my clinical practice and those I work alongside. In acute services, we would tend to see swallowing symptoms more routinely because patients are admitted perhaps requiring support because they're not eating and drinking sufficiently, but in other services we might see more communication symptoms. So where do SLTs see F&D patients? Oh, this has come up all together, but I wonder if I can go back. There we go. So in the research, really, voice has been the primary focus. So patients might present with voice loss or a change in voice in the context of a normal nasendoscopy. But also we might have speech therapists in stammering services, and some of those patients will have functional stammers. Of course, in neuro services, we're well placed to support, but largely throughout the UK, you tend to find us more in stroke services. So Gargalas et al. Did a study in their HASU at King's and found that just over 8% of their admissions to their HASU had functional disorders. And the second commonest symptom for those patients was slurred speech. In terms of mental health services, speech and language therapists are not always routinely commissioned. However, we know well in the literature that F&D is a high incidence of comorbidity in psychological and psychiatric conditions. Pediatric services, we know that F&D occurs across the lifespan. It is rare in children under 10, but there are now some adolescent services that specialise in F&D. Some of you may not be familiar with inducible laryngeal obstruction, chronic cough. It's quite a specialist area. It hasn't just come since COVID. It was present before that. But of course, since COVID, it's received a lot more attention. But it has been identified that speech and language therapists are well placed to diagnose it with our FEES assessment. And of course, underpinning all the specialist services are our community colleagues. And we think around this number of patients are living with F&D in the community, but I think that number is fairly conservative. So I mentioned diagnostics briefly, but I think it's really important to recognise that speech disorders often indicate to us where there might be a lesion before you've even scanned somebody or before you've done other tests into certain progressive conditions. And we know that the presence of a structural lesion doesn't preclude F&D, and speech and language therapists are well placed to support in that diagnostic process. And I'm particularly interested in MS, and this paper reminds us about accurate diagnosis, particularly with my relapsing remitting MS cohort, that perhaps we could avoid using disease-modifying therapies if we ensure that we're actually seeing a new MS symptom, or are we seeing a functional symptom? And of course, in terms of diagnosis, speech and language therapists are not giving that formalised diagnosis. And we know that patients are receiving better diagnoses. There's still a long way to go, of course, as Kim reminded us. But in my mind, it's really critical that when you're giving that, it's like planting a seed, and you've got to then put it in the right environment almost immediately so that the person can do well on their journey going forwards and flourish and thrive. The real challenge really that we're having with our patients is that they understand the diagnosis perhaps now, but we don't have any services that are routinely commissioned for speech therapy to see F&D always. And if they are commissioned, they have to wait for very long periods in order to be able to see a speech therapist. And in which case, those patients are not then benefiting from your important work, because if their communication symptoms are very difficult and challenging, they can't access talking therapy. And one of my colleagues did a survey of speech and language therapists in 2020 and found that generally we don't feel we have the confidence or skills to be able to treat these patients. We do have them, but we need to be able to help speech and language therapists work with FND effectively. And so we developed a consensus recommendation ourselves, and this was an international panel of speech and language therapists met online during COVID times. And really, it helps represent the broad range of functional symptoms that we encounter beyond just voice. And we've hoped to equip speech therapists with the skills to assess and manage symptoms regardless of their clinical environment, but acknowledging that, of course, MDT working is the best practice model. And I agree with Glenn that there's value in having specialist services as well. But many speech therapists have got in touch with us from the consensus recommendation saying they've been able to use it to start commissioning services, or at least give some evidence of why they might see patients with FND. So there are probably too much time would need to be taken to talk about all these symptoms that we might encounter in FND cohorts. But there are shared approaches that I can talk to you about. So the first process that we would take is that we would identify the patterns that we're seeing in front of us through skilled assessment, and we would be aiming to educate the client about using that assessment to try and explain, well, say they have two diagnoses perhaps going on at once. We might say, well, these symptoms are related to your Parkinson's. These symptoms are related to something called functional neurological disorder. But without that detailed assessment, we can't really explain it to the patient properly. And that's something that I often hear from speech therapists is missing. We would then provide them with written information, signpost them to the great charity work that's being done, and then make a plan for therapy. So similarly to my colleagues in physio and OT, what we would tend to see in that initial assessment is that when we redirect attention away from the body, we might see a reduction in symptoms or even a complete resolution of symptoms. And similarly, when we're discussing the symptoms, and often people have experienced very difficult, challenging times before they come to see us, we would see enhanced severity of those symptoms. If another condition exists as well as FND, the symptoms may not fit with that lesion or be disproportionate to the lesion, and we can discuss that with them. Where there might be a consideration of weakness, either in the face or in other muscles, they would tend to look more like muscle hyperfunction. As I put effort into trying to talk, I'm then limited in my movement more than weakness. And as we could do different assessment tasks, we'd see variability in those. The tongue may deviate to one side when we ask them to protrude their tongue, but actually in conversation, when I'm talking about something more pleasant, like a recent holiday, perhaps I see the speech symptoms don't quite align with what I would expect to see with someone with a deviated tongue. So during that therapeutic process, we're helping the client identify those aspects that underlie their physical symptoms and how they might change how they're experiencing their symptoms, and consider together the value of those factors that may have occurred prior to the onset of symptoms, or at the moment of symptom onset, or even now, what's maintaining symptoms, if anything. And it's absolutely true that I think we need to come at it from the patient being the expert. They are the expert in their symptoms, and so I get curious with them about what their experience of their symptoms are and how I might be on that journey with them. So examples from therapy, we might notice and challenge any unhelpful thoughts that might be occurring. If I stammer at work, I'll lose my job. If I start coughing, I won't be able to stop. Identify symptomatic patterns. Obviously, there's many, but some that I commonly see: breath holding, or putting lots of effort in to try and produce speech or voice that's very difficult and trying to ease that effort. Considering the relevance of those factors I just discussed there, maybe recent illness prior to the onset of symptoms, or conflict in conversation with someone particular. So I'm just going to share a video of a client who kindly let me share her video, making links between an experience she had where she was very upset and how that impacted her speech symptoms.
Hey. Maybe you go. Lovely.
So in terms of kind of shared treatment principles, regardless of the speech and language symptoms that a patient might present with, we look to retrain movement patterns into the most typical movement we can. So we identify the movement that's perhaps, or feature that's taking us furthest away from natural speech or swallowing, and we try and retrain that into typical movement, and we extend it into relevant activities to that patient. So is it going for coffee with someone? Is it making a phone call? Is it something related to reading a bedtime story to their children? And modifying throughout any patterns that feel like they're unhelpful to clear speech or swallowing, and developing strategies for setbacks. Of course, with any journey of rehabilitation, there are setbacks, and we need to help the patient to understand that that might happen, but that we can give them the tools to manage them. And so when someone has developed awareness and they can capture that for you, I think it can be a really powerful part of that intervention process.
I have also started noticing where I start saying wrong words. And I've noticed that what happens is my mind is speaking faster than my words coming out.
So to summarise, we know that there is a high prevalence of communication and swallowing symptoms in FND cohorts. We've got an important role in diagnostics, and our consensus recommendations can now support treatment approaches and hopefully commissioning of services too. And obviously we always need more research into treatments for FND subtypes. Thank you.